A 29-year-old female presents with an asthma exacerbation. She is treated with 2 salbutamol nebulizers, 1 ipratropium nebulizer, and IV hydrocortisone. Her rate assessment reveals SATs of 94% on air, respiratory rate of 26, a wheezy chest, a raised JVP, heart rate of 120, a blood pressure of 85/40, GCS of 15, and a temperature of 36.5. She's unable to complete full sentences. So 3 questions now following that 1 vignette. What is the most concerning feature from the assessment? Is it A, blood pressure, B, heart rate, C, the inability to complete full sentences, D, the respiratory rate, or E, the wheezy chest? Question 2. What is the mechanism driving the development of hypotension? Is it A, carbon dioxide mediated vasodilation, B, inadequate cardiac contractility, C, reduced preload secondary to compression of the great vessels, D, sepsis mediated vasodilation and increased capillary permeability, E, steroid mediated hypotension secondary to the hydrocortisone? And question 3, what is the most appropriate next step in management? Is it A, an ammonophlin infusion, B, intubation and ventilation, is it C, magnesium IV, D, non-invasive ventilation, E, salbutamol IV infusion? The answers to question 1 and 2 are based on the pathophysiology of acute asthma, which we'll just quickly talk through. The BTS and SIGN guidelines give a fantastic grading system to work out the severity of asthma exacerbations. This gives us the correct answer of blood pressure, because it's the only life-threatening feature present. Now, why does hypotension occur? In acute asthma, the airway pressure is high due to severe bronchoconstriction. Expiration is more prolonged than usual as it takes longer for air to leave the lungs because of the excess bronchoconstriction. This leads to breath stacking, where patients start breathing in before they've fully expired. This means air can enter the lung, but not escape because of the prolonged expiratory time. Breath stacking causes raised intrathoracic pressure, which can lead to pneumothoraces developing and/or compression of the great vessels. This compression causes decreased venous return to the heart, triggering cardiovascular collapse. So the presence of hypotension should raise the concern that there's decreased venous return secondary to a high intrathoracic pressure. All the other answers are essentially in a less dramatic category. So just looking through the other incorrect answers then for question 2. So carbon dioxide mediated vasodilation. CO2 does cause vasodilation, but it's unlikely to be significant enough to cause hypotension. Inadequate cardiac contractility would cause hypotension, but it's unlikely in a young patient without any cardiac history. Sepsis causes distributive shock through vasodilation and increased capillary permeability, but it's unlikely to be the cause in this case. The presence of wheeze suggests an asthma exacerbation, rather than focal signs in keeping with a pneumonia triggering chest sepsis. And then either steroids, glucocorticoids increase blood pressure through impact on the renin system, so this option is incorrect. And in terms of the management then, the correct answer is C, magnesium IV. IV magnesium should be given to patients with a poor response to initial treatment or if they have life-threatening features. The dose is 1.2 to 2 grams. It causes bronchodilation and may have an impact on the immune response in asthma, although evidence for this last bit is a bit rubbish. The notable side effect of magnesium is vasodilation, which can cause hypotension and a flushing sensation, although this is more common in higher doses used, such as in eclampsia where it's 4.5 grams. Looking at the incorrect answers then, ammonophlin was previously commonly used in asthma management, but it's got a very poor side effect profile, notably tachycardia. It's occasionally used for resistant or brittle asthmatics under specialist supervision. B, intubation and ventilation. This is always a scary thing to do in asthmatics because they're frankly a nightmare to ventilate. Their high airway pressures make ventilating very tricky because of the risk of barotrauma and pneumothoraces developing. In practice, intubation and ventilation is delayed for as long as it's safe to do so. However, it would be the next step if magnesium is ineffective or if the patient declines, but is premature with the current scenario. D, non-invasive ventilation, is not used as an option in asthma management in the UK. There is a lack of evidence to show it benefits patients, and some evidence to suggest it increases harm, largely because it delays intubating and ventilating. It should also be noted that both invasive and non-invasive ventilation will increase intrathoracic pressure and therefore drop preload, causing hypotension. Salbutamol IV infusion is an option, but is not included in the standard BTS management for asthma in adults. It's occasionally used in paediatrics for severe and life-threatening asthma. IV infusions often have high side effect rates with tachyarrhythmias and tremor common.